us know if you can't hear us or see us, but really appreciate the introduction. And I want to thank Roxann, who's been with us for a couple of years here now at Urology Nevada, has a lot of expertise in prosthetic urology and treating erectile dysfunction. So she's going to help me keep this a little bit more lively. We'll try to make this not just reading PowerPoint slides, but talking about patients we've seen and treated, and then we'll go through a little bit of background knowledge about erectile dysfunction, so some education, as well as we're going to talk about how we treat this, which is, I think, the most important part. So I'll turn it over to you, Roxann, if you want to go over definition of erectile dysfunction.
Great. Thank you, Dr. Anderson. Really happy to be here tonight and be able to talk about this issue. It's very important to both of us. Erectile dysfunction is typically a blood flow issue where we are not getting enough blood flow to the penis suitable for intercourse or masturbation. It is very common. This issue occurs in 1 in 5 men, and after the age of 40, at least 50% of men have some degree of erectile dysfunction.
Oh, that's a lot. So over
Yeah.
40 million Americans have some degree of erectile dysfunction, and that could be problems getting the erection or even maintaining it after penetration. So we're really passionate about this as kind of a subset within urology, mostly because it doesn't just affect the man, but it also affects their partner. So it can affect relationships as well, and that's where I find my passion is helping the couple. This is a lot of kind of anatomy as well as how erections happen. But in general, with stimulation, the nerves get excited, and that causes blood flow changes, more blood flow to the penis, and then the veins kind of get smashed and not allowing the blood to leave. And that's how, in general, an erection happens. So we won't go over that too much, but there are a lot of causes and medical conditions that are associated with erectile dysfunction. The main ones that we're going to focus on tonight are heart disease or cardiovascular disease, vascular disease, treatment of prostate cancer, and then diabetes as well. As you can see here, it's pretty common to have one or more of these in men that also have erectile dysfunction. So quickly on diabetes. Diabetes affects, again, over 15 million men, and we find that patients with diabetes often present with erectile dysfunction earlier, and it tends to be more severe. So the same process that's affecting the rest of the body with diabetes also affects the penis. So as we kind of look at anatomy and talk about why pills don't work as much, it's a combination of both a nerve problem as well as a vascular problem. And for diabetic patients, having that problem with the nerves also affects the ability for those medications to really act how they're supposed to stimulate blood flow.
Dr. Anderson, are all men who have diabetes at the same risk of this, or does it depend on how well their diabetes is controlled?
That's a great question. Thanks for bringing that up. As far as diabetic control, uncontrolled diabetes and very high glucose or sugar levels in your blood will make this process accelerate and often present sooner. So well-controlled diabetic patients may not have erectile dysfunction at all, or it may present later in life, similar to a non-diabetic. We've seen men even in their 40s with uncontrolled diabetes with pretty severe problems with erections. So great question. I'll turn it over to you to go over some other factors that also affect erections.
Okay. Well, just some of the kind of common factors that can affect erection is age, like Dr. Anderson mentioned, that poor glycemic control that he talked about. Vascular disease or cardiovascular disease is a big one, so we'll touch a little bit more on that. Certain medicines can affect, like diuretics. There are other medicines too. And, well, back to that heart disease.
exactly. So, for heart disease, um, have you seen patients come in with new onset erectile dysfunction? And have you ever referred them to a cardiologist?
Definitely. I always, especially when I first have a patient come in for this issue, if they haven't at least been worked up by their primary care to make sure that other risk factors for cardiovascular disease are controlled, then I make sure that we go ahead and do that. That's things like checking blood pressure, making sure that their cholesterol is within normal limits, and that they're not using tobacco products because that can affect it too. And if they are, we can work with them on how to decrease or be able to quit smoking.
Yeah. So just because we're in a urology office, we do try to think about the whole patient, not just the penis and the erection. And so we may be able to find diseases of the heart, like coronary artery disease, before it actually becomes a problem like a heart attack. So the arteries that go to the penis that supply the blood flow to provide the erection are really small, smaller than some of the blood supply to the heart. So if there's issues in the blood supply to the penis, then there's also going to be issues to the blood supply to the heart. So it's really important that we think of them as kind of a disease of the system, and it's a major risk factor for problems with erections.
Mhm.
Can you go over some of the ways that we try to risk reduce?
Right. Yeah. There's definitely things you can do even before you come in to see us. I always talk to patients about lifestyle changes that they can make to decrease these risk factors. That being things like diet. You can look up on the American Heart Association. They have recommendations on diet that helps prevent heart disease and vascular disease. Physical activity. If we're not moving around, we're not getting that blood flow going, and that definitely puts us at increased risk of vascular disease anywhere in the body. Weight loss can be helpful always, and sometimes that can even contribute to low testosterone, which I'll touch on in a little bit, not how that affects having issues with erections. Smoking, like we mentioned, and just reducing stress in general.
So it seems like if you have a healthier life, then you're more likely to have better erections.
Yeah, and the healthier we are, the less risk we are at um, needing more medicine or further therapies down the road.
Yeah, that's great. So you were talking about low testosterone. How are these two things related?
Yeah, well, low testosterone is very common in men. It is affected by a multitude of factors, as you can see here on the screen. And it's something that directly affects ability to get erections just because it is an important part of men's ability to get erections and have libido. It's something I certainly screen for whenever I have a man come in for erectile dysfunction, but I also treat low testosterone or hypogonadism even without issues with erections. And so there are a lot of different ways that we can do this. I think.
Let's go on. So you were saying there's different ways to replace testosterone,
Yeah.
and you're, I would argue, almost more of an expert than I am in that you're helping a lot of men, whether it's injections, patches,
Mhm.
gels, implants. As we talk about erectile dysfunction, we also want to be talking about this as well.
Definitely.
Excellent. Um, a common cause for problems with erections is treatment of prostate cancer. And it's not that the radiation or the surgery went poorly, it's just a known side effect of the treatment of prostate cancer. So, oftentimes prostate cancer is treated by removal of the prostate and or radiation, sometimes a combination of both. And the main reason why it affects erections is that anatomically the nerves that go to the penis are right next to and kind of plastered right on top of below the prostate. So pictured here in that center picture. and the surgery as well as radiation can affect those nerves. And for some men, that can be pretty serious. So I would say about half of men with after radiation experience worsening erections, and that can take some years to see. So it's a long process. And most men after prostate cancer removal surgery or prostatectomy will see a decrease in their erections. So do you want to, this has a lot of information on this slide, and we could do a whole talk about Peyronie's disease. You've probably seen the carrot commercial, but do you want to explain what it is and why we're talking about it with ED?
Yeah, I'm happy to. Peyronie's disease is a common urologic problem that we see. It is due to curvature of the penis that's caused from a plaque or scar tissue. Typically, there was, a traumatic event previously. Sometimes, though, men don't know what caused it. And that plaque causes a certain degree of curvature with erections that can make them painful and cause issues with erectile dysfunction as well. We certainly treat this in our office. There's a lot of different treatment options, as you see down at the bottom. It's something that if you're suffering from erectile dysfunction and Peyronie's disease, we can certainly treat both together.
Absolutely. So we won't go into too much more detail about that, but if you experience this, we're happy to talk about one or both. Uh, so moving on, we're going to transition to a little bit more about treatment. And before we get there, there's lots of things on the internet, and there's lots of experimental treatments. There's lots of clinics that will offer all sorts of different treatments, and here are just three of them. And there is some data that would support some of these treatments. But as far as our American Urologic Association, which we base our guidelines on and our recommendations, is that the following therapies are considered investigational. So if you're really interested in one of these therapies, and I would encourage you to seek out a study where they're doing a randomized study to see if this is actually worthwhile. Outside of studies, these tend to be clinics and providers that will take cash pay to do these therapies. And so currently we are not offering these at Urology Nevada because we want to be following our guidelines. So moving on to therapies. Do you want to give a brief overview of what we're going to talk about here?
Yeah, so lots of different therapies for erectile dysfunction. One of the most common ones that we hear about are oral medications, things like Viagra, Cialis. There are also injectable therapies, vacuum erection devices and constriction rings, urethral suppositories, which come in gels or like a tablet, and then the penile implant.
Great. And that's typically about sort of the direction of where we go as far as offering these different things, but it doesn't have to be a linear, you don't have to try everything before we get to the penile implant and vice versa. So let's talk about the oral medications briefly. You had mentioned Cialis and Viagra. They work pretty much the same.
Mhm.
And I would say most patients are either trying those from primary care doctors or we're prescribing them. And do you think they work well?
I think in general it's a good starting point, but I think a lot of times by the time men come to us, they've already tried some of these things and they're either not getting good success with them or just not as much success as they would like.
Yeah, I think that's pretty accurate, and it can be a frustrating process for some guys that think that this is the only thing out there. They tried
Mhm.
the pills, they did the maximum dose, and it's still not working. So, for mild or moderate erectile dysfunction, they're great medications, and they can work well, and that may be all that you need. But for a lot of men, that's not enough. The next thing is called intracavernosal injections, or injecting a small amount of medication directly into the side of the penis. Most men, when you introduce this topic, their eyes go like this. They're like, "What are you talking about? Needle next to the penis?" And I just want to reassure you that this is also a good option, and it's a tiny diabetic needle. And we teach you how to do this so you know exactly how to do this safely. And for a lot of men, it works pretty well. It's injecting a combination of medications that go directly into the penis that stimulate blood flow. And for many men, that may be all that they need, and that works well. What do you see as some of the drawbacks of this medication?
Well, as far as the medication, I think probably the biggest drawback is the injection site reaction, which doesn't always occur. But that's why we take the time to teach these patients so that they know what they're doing at home.
Hmm.
If you ever come in for an injection training, it's always good to bring your partner if they're going to be helping you out at home so that they know what to do and how to help you too. I have a lot of men who are really worried about doing this, and then they come in for injection training with me and they do great.
Yeah.
They barely feel it. So I would say, I think that really a lot of men are actually pretty happy with doing the injection therapy, especially if they fail on oral medicines. And one of the nice things about it is that it's quick to act. So about 5 to 10 minutes, and then you're starting to get an erection. Whereas some of the oral medicines can take up to 1 to 2 hours.
Yeah, absolutely. So a great overview there, and we can always give you more information about this if that's a new concept and you're interested in that at follow-up appointments. And we'll get to that towards the end of our talk. A vacuum erectile device, we won't go into too much detail, but these are available online at local sex stores, things like this. People call them the penis pump. It basically pulls air out of a cylinder, increasing blood flow to the penis. And then there's a small ring that we recommend soft constrictive bands, not anything metal. And that needs to go to kind of hold the blood within the penis. And then you take the penis pump off, and then you're ready to go. So for some men, this works really great. The most common things that I hear from guys is that it's not very realistic. The penis feels kind of cold, and then ejaculation can be kind of uncomfortable dealing with the ring and that whole process. So they're very common. They typically don't cause any long-term damage or anything like that, so they're pretty safe, and that is an option. And then, do you want to talk about this?
Yeah, so urethral suppositories are another option. I would say I probably don't do these as much as others, mostly
Mhm.
just because of the drawback that it can sometimes cause some irritation to the urethra. But I have some men who prefer this option. There's a few different brand names. It does come in a gel too. Some men will even use like a low dose Cialis with the gel. So that's an option too. The suppository goes into the urethra about 5 to 10 minutes before you want to be active. It's something that you could do instead of injection therapy that's going to work quickly and effectively.
It's very similar medication. It's just the delivery, either a small injection or a suppository. And I would echo that the urethral discomfort or burning with peeing afterwards are kind of the main reasons why guys typically don't like it.
Mhm.
So moving on, we're going to talk about penile implants. And what I tell guys is we can help you with erections, whether that's oral medications, injections, pumps, or even a penile prosthesis surgery. So, this is something that when you introduce this topic to guys, their eyes often get even larger. So, you're saying surgery for erections? Yes, this is actually a very effective way to help men with moderate to severe erectile dysfunction. Also, men that don't tolerate the oral medications or the injections, they may be able to get erections, but they could have severe side effects. So those aren't good options because of side effects, not necessarily that they don't work.
Mhm.
Over 90% satisfaction with both the patients and their partners, which is pretty surprising. They've done studies and asked those questions after they've healed up from this surgery. So we have a video here, or these are three different types of penile prosthesis. There's the most simple is on the right side of the screen called a malleable. That's two cylinders that go underneath the skin within the penis that bend up and down. There's no pumping, there's no fluid. It becomes a little bit more complex as we go over to the left side all the way to a three-piece inflatable device. And this works by transferring saline or salt water from a reservoir that's behind the pubic bone by use of a pump, and that pump takes the fluid into the cylinders. So it's very realistic when it's deflated, and then very firm and adequate for penetration when fully inflated. So, uh, as far as this is kind of talking about some of the specifics to Boston Scientific device, in that they've been making these devices for over 45 years, and they are coated with a special antibiotic coating to decrease the risk of infection. So, and this is just kind of labeling the three different parts in a three-piece penile prosthesis. Okay, here's the video. So we're going to play the video and maybe do a little bit of talking while it's going. This is kind of like a cartoon animation that shows just how it actually works. So as we kind of look in, this would be like a man that's already had one inflated. This is using the pump and pumping the bottom part of that pump in the scrotum, sending the fluid from the reservoir up into the cylinders. So you can note that the cylinders go all the way in towards the head of the penis or the glands, and then here the cartoon is deflating it, so allowing the penis to go to more of a deflated state. So hopefully that's helpful to kind of explain just how this works. So, all right. So now we're going to talk a little bit more about nitty gritty of surgery and how this would work. And I'll start with saying that this is becoming a pretty common surgery that we do here at Urology Nevada, somewhere between 4 to 6 a month. And that's just to say that a lot of guys have gone through all these treatments. They've tried this, and after you heal up from this surgery, the vast majority of our patients are some of our happier patients, because for many of them, I'll give you an example. I had a patient that was just over 50 years old. He has a long history of type 1 diabetes, so he's had diabetes his whole life, and all through his 40s, he'd been trying all the different medications, the injections, and nothing was working. We finally got to a point where we had good glucose control, safe for surgery. He recovered from his penile implant, and now, over a year later, he is telling all of his friends because he's so happy with it, and it's really brought him and his partner a lot closer, because before that, they had over a decade of really minimal ability to have penetrative intercourse, which was an important part of their marriage. So do you want to go over generally what the recovery time looks like with this?
Yeah, I'm happy to. Typically, these men are going home same day, although sometimes we do keep them in the hospital overnight. Oftentimes, you will have a catheter, or I'm sorry, a drain that we'll remove in the clinic within a couple days after surgery. We have a lot of follow-ups with you afterwards, just to make sure that you're doing well and recovering as expected. We want to make sure that you know how to use your device well too, and so that when you're fully healed, you feel confident, and you can be intimate with your partner with your device. Uh, for most men, this looks like 4 to 6 weeks after surgery, being able to have intercourse. Before that, really those first couple of weeks, we're just focusing on leaving the device partially inflated to allow for everything to heal appropriately. About week 2 or 3 is when we have you come into the office to start to learn how to cycle that device. And that's when we go through inflation, deflation with you. After that, couple weeks later is usually when you have recovered enough, everything has healed as far as incisions, and you're less tender so that you can start using that device with your partner.
Yeah, those are some of my favorite visits, when you come back and see one of us, and you're like, yep, see, I can do it just fine. We give you a few tips or tricks, and then it's what we call a green light visit, meaning you're able to start using the device. So, and these are all kind of averages and time frames. So common questions have to do with insurance coverage with these devices. It is mostly covered by Medicare plans, and thankfully that's a lot of our patients. But a lot of patients are younger than 65, and so it really depends on the insurance. So we have a prior authorization process, and there are ways that we can help do appeals and things like that. So I won't get into too many details because every insurance company is a little bit different, but there are a lot of resources that we can help try to get this covered. So these are some of the benefits here as far as some of the things we've already even talked about. So affordable, being that it's mostly covered. Long lasting, that's a good point to bring up.
Mhm.
A common thing that we go over is how long do these work? What do you say on average?
Typically about 7 to 10 years. I would say 10 years, is common. I have seen men before who've had it even longer,
Yeah.
up to, like, 20 years before, which is great. But it's a device, that's mechanical with a inflatable pump, so, those do fail eventually, and we just have to, replace the pump when that occurs.
Yeah. So uh, it these are all kind of averages. We say about 10 years, and it will depend on how young and how active you are with using the device. But they are easily removed and replaced if there is an issue. The natural feeling is that with these inflatable penile prostheses, once you've healed, it's pretty hard to even see the scar. If you're walking around naked in a locker room or something, nobody's going to know that you have it. And everything is underneath the skin. So it's kind of concealed, and it allows for spontaneity. And this last point on this slide, I think, is an important one to go over. With oral medications, you have to remember to take it either that morning or an hour before, empty stomach. Is it going to work this time? I don't know. With the injections, you will need to, again, have it with you, have the syringes, make sure you have, if you're traveling, make sure it stays refrigerated. So there are
Mhm.
some logistical things that you don't have with a penile implant. It is ready to go and it stays firm as long as you want. And then you have to deflate it when you don't want the erection anymore. So in that sense, it allows for a little bit more spontaneity. You have everything you need, and it's all underneath the skin.
Dr. Anderson, when men have these devices placed, do they still have the same sensation or feeling during intercourse?
Great point. The vast majority of men have the exact same sensation. So the nerves to the skin and the penis should not be significantly affected from this surgery after you've healed up. And then also, as far as ejaculation, should not be affected for most men, and that experience of orgasm should not be affected. So, so most men, it's pretty much the same as it was before. Think of this as a hydraulic device that allows for a firm penis. It's not doing a whole lot else other than allowing for penetrative intercourse. So, with any surgical procedure, there are risks, and I go over these in great detail. And so, some of the issues that we can see with penile prosthesis are things like issues with infection. That infection rate is very low, like 1% for non diabetic patients, but it's a big deal when it happens. Discomfort, swelling, bruising are all common during the healing process. It's very uncommon to have continued pain after outside of this 4 to 6 week healing process. We talked about mechanical failure, and that could happen typically after somewhere around 10 years. Rarely we would have issues with a device going places that it's not supposed to, and that could require a revision surgery where we make sure it goes back exactly where it goes. That revision rate is far less than 5%. So let's see. Here's more information, and there's so many different ways that you can get more information. edcure.org, great website through Boston Scientific. You can do the QR code there. That brings you to a quiz that says, okay, how serious is this ED? That's called a SHIM score. There's also a text message option. And I have my personal website that has information. That's my name, RossAndersonMD.com. Lots of ED information about how we treat it, different options. There's videos of me saying pretty much the same thing in different ways. So lots of opportunities there. So we got through that in about a half hour. I hope that wasn't too fast. We will have the ability to have this online for you guys here probably by next week if you want to go through it again or read through some of the parts that we skimmed through for the sake of time. But I hope this was helpful as far as giving more background information, talking about different treatment options, and what we want this to hopefully accomplish for you guys is to say that we want to be engaged with you. If we sent this to our Urology Nevada patients in an effort to say, you know, maybe there's some guys out there that have failed the medications and just stop trying. I hope this shows that there are other options out there. And to hopefully re-engage our patients, our plan is to have, if you'd like to set up an appointment to talk more about some of these options or to go over your specific case. We're not going to go over your specifics tonight in the question and the answer. So I hope that the questions you have are kind of broad and not pertaining exactly to you. But we do want to set up appointments. And I think we've got some appointments kind of saved in Roxann's schedule over these next few weeks. And if you want to, you can call and request that. Just say that you attended our webinar and we will try to get you in timely fashion. And the plan would be to have you see them first, Roxann,
Mm-hmm.
and then if we need to start talking about things more than just medications or injections, then I'm happy to also be a resource. The nice thing is Roxann and I sit right next to each other. We share patients. We talked about all these follow-up visits like after surgery. We're both seeing you after surgery, so we try to share that, and oftentimes getting another way of thinking or another way of explaining things can be really helpful.
Definitely.
Do you have anything to add about that or the process moving forward?
I don't think so. When you are trying to make that appointment, you're welcome to call our office, or you can use the phone number that we have here with that extension number 3. And like Dr. Anderson mentioned, just mention that you came to the webinar, and we have some slots open in my schedule as early as towards the end of this week.
Great. Thanks for being willing to do that. That's really great. There's also a way to go on our website and request an appointment online, and that will also go to the schedulers. Now just say you can mention that you were on the webinar and you'd like to schedule some follow-up. So lastly, thank you very much for being here. For those of you that made it through that long presentation, thank you. As far as questions, Carlos, do you want to start screening those or letting us know what you'd like us to answer?
Yeah. So one of the questions we have here in the chat box says, 1 year